I'm delighted to learn that the Indian Association of Interventional Cardiac Surgeons is starting to teach cardiac surgery residents the implications and wire skills which are very necessary in today's environment. I guess I must be the last surgeon who was trained in all aspects of cardiothoracic surgery, which included lungs, esophagus, cardiac, as well as vascular surgery from head to the toe. We've also had to be trained for angiography, pacemaker incision, and cardiac catheters, etc. Of course, as things progressed, we cardiac surgeons started to behave like drunken millionaires and started throwing away all the things that we needed to learn. Therefore, we come to the situation now where we have become a one operation surgeon. And as you well know, if you are one operation surgeon or one product company, you are very vulnerable. And in today's developing world, a slight development in the techniques can make you almost extinct. We also have to contend with the fact that most of the advances in the technology are done by multi-million companies. Their only interest is to make money, and they want quick solutions as well as things that need to be repeated. Because if you do a CABG and the patient does well for 20 years, they lose interest. They want to have angioplasty and temporary procedures that have to be repeatedly, and the companies can continue to make money on these patients. I might as well point out at this stage that initially coronary angiography by the Stone's technique was a different ball game. The technique was difficult and it needed a lot of finesse to do that. But with the advent of the Judkins catheter, Melvin Judkins, a radiologist from Oregon, made this catheter, which is a self-seeking device, and it easily goes into the orifices of the right and left coronary artery, and it's easy to do a coronary angiogram as such. We also have to worry about the fact that millions of dollars are being spent on percutaneous valves, etc. In the US, most institutions have a system where they have a heart team, and percutaneous valve is done alternately by the cardiologist and the cardiac surgeons. We have no such arrangement here. I think we have to regain all the lost territories for the last several decades. One easy way to do that would be to have an hybrid operating theatre. The hybrid operating theatre will allow us to control the entire cardiology and cardiac surgery procedures. You can do angios, endovascular, and the combined procedures and hybrid procedures. Also, these days, most operation theatres have a C-arm that allows us to do permanent pacemakers and ICD implants, etc. And the advantage over these things is in the operation theatre, we have a much more sterile environment than the cath lab. So therefore, we can reduce or eliminate the chance of infection of all these in all these procedures. We also have to enlarge our scope and learn about thoracoscopic surgery, robotic surgery, and all these other things that will make the operation simple and less invasive that we have today. So I encourage all our young surgical colleagues to embrace this and further develop wire skills so they can compete with the cardiologist. But my advice would be not to eliminate the cardiologist, but to work together with them so both of them get the best contribution to get the best treatment for our patients. I would like to remind my younger colleagues that we as cardiac surgeons have always been leaders in the field. For the last 50 years, we have led the entire medical fraternity. Over the last few years, we've been losing ground. The time has come with increasing skills in all spheres, we will be able to recapture the lost ground and reclaim all the territory that we have lost in the last several years. I wish you well.